Good afternoon, everyone. My name is Maya Luria with TMC for Seniors, and I'm excited today that we are kicking off June with our Hearing Month. And I have Dr. Stephanie Bourn with me here. She is from Center for Neurosciences as well as Tucson Medical Center to talk all about tinnitus. So welcome. Thank you for being here, Dr. Bourn.
Great. Thank you so much for having me. I'm excited to talk to everyone about tinnitus.
So yeah, and I know this is something that affects so many people. So we are so glad you are here and can hopefully shed some light as to things that people can do if they have tinnitus.
Yeah, absolutely. Absolutely. All right, let me get my share. All right, great. You can see my screen okay?
Yep, you're good to go.
Perfect. Okay, so like I said, I'm Stephanie Bourn. I'm an audiologist. I'm the lead audiologist at the Center for Neurosciences. I'm also a contract audiologist over at Tucson Medical Center as well. Over at TMC, they have had a long and robust pediatric audiology program, and more recently have really been putting in a lot of effort and focus to develop their adult program as well. So I'm over there helping to get that adult program up and running. I've been seeing patients for several weeks, and there's an audiologist there, Dr. Shauna Bone, who's also been seeing adults as well. So it's just another really great option in town for adults to be able to have comprehensive audiologic care taken care of. So this is me. Of course, my picture, this is my partner at Center for Neurosciences, Mary Rose Goldstein, as well. The ear and hearing, I can tell you a bit about my clinic more specifically than my primary clinic, is that the ear and hearing clinic we're housed within a private practice actually called the Center for Neurosciences. It's actually a neurology, neurosurgery private practice. It's a very large practice. There's more than 40 providers in our clinic. But in regards to ear and hearing, we have the most experienced otologists and neurotologists in Southern Arizona. We have 2 full-time audiologists. We have a part-time audiologist. We have 2 audiology externs, which are students who are completing their doctorates in audiology. We really pride ourselves in personalized clinical care coordination. We're really, really hard, especially for parents, because we're in Tucson and we serve the greater Southern Arizona area. We see patients from from several hours away. And so we really work hard for our patients that are coming from a geographic distance or maybe have just difficulties getting into the clinic to really consolidate their care as much as we can and maximize their time. If you're going to come to the clinic, let's have you see otology. Let's do some MRI imaging. Let's do your medical visit, their surgical visits as well. You're going to come, you might spend a half a day with us, but we're going to try and get everything done so you don't have to make several trips back and forth as well. We really offer a comprehensive hearing and vestibular program here. So we really pride ourselves in having very, very comprehensive diagnostic evaluation. We also offer extremely comprehensive treatment options. We are very fortunate in our clinic, and we offer all the treatment options, all the way from hearing aids to various implantable devices. And we really have a state-of-the-art implantable hearing devices program. We're actually one of the larger cochlear implant centers, certainly in Arizona, but across the country as well. And then we also, in addition to all that, we have a complete infrastructure for clinical research. And we've at this, as of this time, we've published about 5 papers out of our group here as well. So we're always working to really see how we can add to the literature in our field to really help improve clinical practice amongst our colleagues too. So we just really pride ourselves in providing unmatched care in Southern Arizona for all disorders of the ear, as well as just the lateral skull base too. And here's just a great picture of our team too. Again, our vision is to really provide this personalized, compassionate, and state-of-the-art care that really the goal is always to generate very high outcomes for our patients, but we also want our patients to be really happy with their outcomes too. So this is our whole wonderful team that we have. All right, okay, let's get to the good stuff. Let's talk tinnitus as well. Tinnitus is a big deal for a lot of people. All right, so first off, what is tinnitus? Well, tinnitus is defined as being the perception of sound when an actual external sound isn't present. So tinnitus is sort of literally all within your own head. It's not something that other people can hear. You can't lean into somebody and hear the sound that they hear. It's completely within your own head as well. It is most commonly described as ringing, buzzing, humming, chirping, crickets. It can really be a kind of a real wide variety of sounds, but those are kind of the most common sorts of sounds that people have. Sometimes people even say they get different sounds. That sometimes I might get a ringing, and other times I get a low buzzing, humming. Doesn't matter. It's just any sort of sound that your brain is generating for you. Well, the prevalence. So how common is tinnitus? Well, actually about 15% of the general population is affected by tinnitus, and it affects about 50 million Americans as well. So it is actually a really, really widespread and very common condition that patients or symptom that patients will describe. There's about 20 million Americans report bothersome tinnitus. We'll talk a little bit more about bothersome, but what that means is, no surprise by the term I've used here, but it really bothers them a lot, and it starts to become a real emotional stress response for them. And then even about 1 in 200 cases of tinnitus is considered to be severely bothered. So you've got 15% of the general population has it. About 50 million Americans have tinnitus. 20 million say, hey, it's real bothersome to me. And then about 1 in 200 it's really severe for them. All right, so tinnitus is more common in older adults versus younger adults. It can actually develop at any age, but it's more common in older adults. It's more prevalent in males than it is in females. And there are what we consider high-risk groups for tinnitus, which includes people that were active military and veterans, and so active military duty, and then those that have served in the military in active duty. Those that are exposed to a lot of noise at work. So certainly people that work in construction. In Arizona, we certainly see a fair share of people who worked in the mining industry as well. Factory work, anything where you're just around a lot of constant noise, high level noise. Musicians, again, that's noise is what that is, but you're very often in close proximity. I saw somebody recently who was a dancer, and so certainly she was around a lot of live music, so she had some noise exposure from that. Motorsport and hunting enthusiasts. So you're riding a lot of motorcycles, you're firing a lot of guns, especially without hearing protection, you're more likely to develop tinnitus than someone who does not as well. All right, so there are kind of two main types of tinnitus. In the first, those are subjective tinnitus and objective tinnitus. So subjective tinnitus meaning that it is completely, it's only heard by the person who experiences it. So like I said before, tinnitus is typically it's literally just all in your head, that only you can hear it. And so we're just completely reliant upon you describing your tinnitus. What does it sound like? How loud is it perceived to you? So it's completely your own subjective report of that, versus an objective tinnitus is one that I can actually measure it. Somebody else might be able to hear it, or I might be able to put a little tiny microphone in your ear and I can actually measure the tinnitus. That's extraordinarily rare. You can see an objective tinnitus that can be measured or heard by someone else is less than 1% of cases. So more than 99% of cases are subjective, where it's just a person reporting that they're hearing the sound inside them. Again, it's often described as hissing, chirping, humming, buzzing, whistling, clicking, whooshing, roaring. It can even be music. It can even be voices, and just really any kind of number, any kind of auditory perception, any sort of sound perception that you can get in there. So this subjective tinnitus, so I think something that's important to know about tinnitus is a symptom. It's not really a condition or a disease. It's a symptom. It's something that you experience and that you report. But again, it can vary a lot. It can be constant, where you hear it all the time. It can be intermittent, meaning it comes and goes. It can fluctuate, so sometimes it's louder or softer. It can only be in one ear. It can even be in both ears as well. It is almost always related to hearing loss or conditions that cause hearing loss. So, we might develop hearing loss. Maybe someone was born with hearing loss, they have a condition that caused hearing loss, or they developed hearing loss as the natural course of aging. But there are also things that cause some hearing loss, things like excess wax. So if you get a big buildup of wax in your ears, well, you're not going to hear as well. Your ears are kind of plugged up. You can have a buildup of wax and you're like, wow, my ears are really ringing. And then when the wax gets cleared out, the tinnitus goes away or reduces. You might get an ear infection. Same thing. When you get an ear infection, that's a buildup of fluid behind your eardrum. That actually causes some hearing loss where you tend to feel like you're underwater a bit. When that happens, you might develop some tinnitus. But then when the ear infection clears up, the tinnitus goes away. A head cold, we all know that feeling of when we have a head cold and you just kind of feel like your ears are plugged up, or like when you go in the mountains and things like that. If the head cold is kind of enough or persistent enough, you might get some ringing in your ears that again goes away when the head cold clears up. And then there are some middle ear kind of these muscles. There can be some disorders with that can cause these kinds of fluctuations in hearing, which then can cause some fluctuation in tinnitus as well. Tinnitus is usually by itself, but it can be accompanied by a kind of sudden change in hearing. It can be accompanied by vertigo, the feeling of like you're spinning around, or fullness, again, this pressure or fullness in your ears. We're most concerned, I'll talk a bit more about that later, about the red flags, but we're most concerned when these things are sudden and dramatic. That's always the thing, is a sudden and dramatic onset. And typically when it's sudden and dramatic in one ear, versus it being in both ears. When someone tells me they have a change in both ears, I'm less concerned about it being a serious condition. That's a red flag for something as well, too. The tinnitus, again, like I said, it can kind of fluctuate. We all get tinnitus from time to time. I often say, gosh, you'll get that where you might get one ear, you'll just suddenly get this like beep, and then it just fades out. Maybe it lasts 5 seconds, 10 seconds, 15 seconds. That's no big deal, sort of a thing too. But some people who have tinnitus, they just might find it kind of fluctuates up and down, or might modulate changes in its kind of tone. So causes of tinnitus. So there are, if you look, research tinnitus, it's like, gosh, there's over 200 causes of tinnitus. But again, some of this is what I've already said. It's, again, ear infections, noise exposure. I mean, many of us are guilty of having gone to a concert and walking out of the concert and being like, oh my gosh, my ears are ringing, right? Your ears are so ringing, and they might ring for another day or so because of such noise exposure. You might have sinus pressure. You might have a buildup or impacted wax. You might have some medical conditions or medications that are unrated. So changes in medications can for sure cause tinnitus. I mean, the most common side effects for medications are dizziness and tinnitus. So that's something to always pay attention to is, boy, did you have a change in medication and then you have developed some tinnitus, because it may just be a side effect to that. Cardiovascular disease, so any kind of restriction of blood flow or heart disease, hypertension, a malformation of blood vessels. Your body's got to be able to pump its blood through, fully, so that your body's well oxygenated too. So that can sometimes contribute to tinnitus. Head and neck injuries, skull fractures, TMJ, those types of things can kind of, contribute to stroke. We certainly have seen some patients who have that, who have stroke, and have noticed that as well. But again, I kind of want to actually, most of these many of these actually relate back to hearing loss. So again, keeping in mind that most commonly, tinnitus is related to hearing loss. That's really the primary, the driving, theory behind tinnitus. And what we focus on is that for the vast majority of patients, the tinnitus is because of hearing loss. That's why, again, it's a symptom, not really a condition or disease on its own. Okay. So this is just kind of a pie chart looking at the causes of tinnitus. So you'll see there's things like noise exposure or trauma, ear infections, drug interactions, right? There's a whole bunch of these things that make up, 20, 30, 35%, but the majority, we don't know why. We don't have a specific cause, but again, I can almost always patients, I can pinpoint hearing loss. And so we have to say, well, gosh, that's ultimately the generator or the catalyst for the tinnitus is the hearing loss itself. Again, most cases of tinnitus relate back to some type of hearing loss. Okay. So when we get down to kind of the anatomy and theory of tinnitus, so the exact pathophysiology of tinnitus is not really completely understood, although there are kind of several theories out there. But again, really the primary, theory at this point is that it's a response to hearing loss is what it is. It's a brain phenomenon, actually. So again, if tinnitus is present, there's likely some type of damage or change in the auditory system. So damage meaning hearing loss, or change to the auditory system, you develop hearing loss, you know. So those are almost always, again, the kind of pathophysiology of the tinnitus. And it's the damage or the change, the shift, that's likely the generator or the origin of the tinnitus. So I think when I think about tinnitus, you know, onsetting for patients, you know, our hearing, when regards to hearing, the hearing changes over time. And for most of us, it's just a gradual, slow change. And so that's why we don't really notice, you know, by the time very often when someone comes to see me as an adult, in their later in life, and they might say, well, I think I might be not hearing as well. I almost always diagnose hearing loss, and who knows how long they've had it, because it's kind of just crept on real slowly, just a little change, a little change, a little change. But at some point you get enough of a change, it changes just enough that you go, oh, now I notice it, right? So, you know, that is just kind of that tipping point where then, oh, now it starts to affect you, and you either notice the difficulty you're having with hearing, or you get enough of a change at just the right frequency that, oh, now your brain starts to generate, you know, tinnitus. And so then you actually experience that too. I kind of think of it, this is going to sound silly, but I think of it sometimes like weight, right? So we can all sometimes be like, well, we're overeating a little bit gradually. You're kind of overeating. You just kind of are like gradually putting on a little bit of weight. You put on a half a pound, you put on a pound, you know, but then at some point you put on enough pounds that, oh, now your pants don't fit. And so you have to buy new pants. So there's a range where you can have some change that it doesn't really affect you, but then at some point, whoa, it's enough that it affects you. So it's the same thing with hearing loss, is that you can have this gradual change to your hearing and you're not really noticing it, but at some point it shifts enough that now you're having more difficulty, or now you notice an onset of tinnitus with it. All right, so again, thinking back to the pathophysiology, tinnitus is often thought as the auditory system version of phantom limb syndrome. So many people know about phantom limb syndrome, this idea that a patient who has maybe lost a limb, they lost an arm or a leg, but they will still continue to report that they feel pain from that site, or that they almost can still feel like they still have that limb on there. They can describe feeling things with, you know, a hand or fingers, but they no longer have a hand as well. So for the auditory system, for the hearing system, when there is a damage or a change to the auditory system, such as you get with hearing loss, so you're suddenly not hearing as well as you were, your brain attempts to kind of fill in the missing pieces by generating its own sound. So it says, gosh, I know there was sound there before. I'm not going to stop trying to find that sound. And it tries to fill in those missing pieces. So the way hearing works in our normal system is that in our normal system, the hearing nerve actually fires in response to sound, right? So the ear picks up the sound and it sends it in. And nerve actually starts to fire, and that's what it is. So it fires in response to sound, and then the brain sees the nerve firing, and that's how they communicate to one another. Well, when we develop hearing loss, our brain, the nerve is missing input. It's like, gosh, it's missing stuff, and it knows it used to get that input. So what happens is that the nerve starts to overfire to make up for what it's missing. I often say that the hearing nerve is a very type A personality, and it says, I used to always get these sounds and now I'm not getting it. I probably just need to work harder. So now it starts to overfire, right? So it's going to work really hard and it's going to overfire. Well, the brain now sees the nerve firing a whole lot. Well, the brain is also kind of a type A personality, and it sees the nerve firing. And so it figures it needs a sound. So it just gives it a sound is what it gives it. And so the brain and the nerve kind of get into this funny feedback loop where the one is firing a whole bunch, and so then the brain is giving it a sound. So then the nerve that's overfiring is getting rewarded by that sound from the brain. And so they just kind of keep it up. And it's whatever the sound is that the brain gives the nerve, it can be any type of a sound. So like we said, it's often humming and buzzing and chirping and crickets and ringing. It's very often those types of sounds, but it can be any sound, any kind of a feedback loop that the brain and the ear get into. Like I said, it can even be music. For patients who get music, who get musical tinnitus. That's much, much, much more uncommon, so much more rare to get musical tinnitus. But for patients who get it, this is different than what you would call an earworm. An earworm is when you get a song stuck in your head and you just can't, you're like, oh my gosh, I just have this song running through my head. That's called an earworm. Musical tinnitus is different. It is very often not music a patient even knows. So it's not like getting a song stuck in their head. It's sometimes they'll describe it as like, I just hear instruments playing. I've had patients say, I hear banjos. Sometimes it's bad music, like dissonant music. So like not good music. I have one patient who hears country music. She hates country music. So it's not necessarily music you know, it's not necessarily music you like, it's not always good music. Like I said, it's very different than it being a song stuck in your head. So that's musical tinnitus. Voices, I always say, nobody ever wants to tell you when they hear voices, right? It makes them nervous to say that. But it's different than, so voices, it's usually described as just chatter. People will often describe it to me as if they were like, that there are like people behind them talking quietly. And the way I describe it is people will often say that what they feel like is that they're like looking like there's someone behind them talking is how it feels, just real low. Or again, just kind of hearing, like say, almost like if you were at a cafe or something and you could just kind of have people chattering around. They're not really, it's not specific talking, at you or anything. I once had a patient who told me she thought she had a spirit or a ghost in her home because she would sometimes hear like voices, but they were kind of far away. So they weren't distinct or anything like that. And then, so she thought, oh gosh, I might have like a ghost or a spirit in my house. But then she left her home and was somewhere else. And then she realized she could still hear it. And so that's when she realized that, oh, it's within her own self. So like I said, no one likes to tell you when it's voices. Hearing that kind of chatter and things like I've described, that's fine. That can just be, tinnitus, that's voices. That's the feedback loop your brain and your nerve have gotten into. When you need to be concerned is if the voices are talking to you. They're talking to you, they're talking at you, they're telling you to do things. That's a mental health disorder, and that is something that you do need to see a mental health professional about if that's the case too. So, but it's just a fascinating, like I said, kind of feedback loop that the brain and the hearing nerve get into, as well as that this missing input, you develop some hearing loss, the nerve starts to overfire to make up for what it's listening for, and the brain gives it a sound. Who knows what that sound is, but it's most commonly ringing, buzzing, humming, or chirping, and they just kind of keep doing it as well. All right. So now just because you have hearing, so even though tinnitus is caused almost always by hearing loss, just because you have hearing loss does not mean you will definitely have tinnitus, okay? However, the worse your hearing loss, the more likely that you will tell me that you do have tinnitus. So tinnitus is, because it is subjective, it's completely within your own head, and it's your own perception of it, about how loud it is, about how bothersome it is. There just is no correlation between how much hearing loss you have and the severity of your tinnitus. So it's not like someone who has, I have a really big hearing loss, that means I have really bad tinnitus. And it just doesn't work that way. Sometimes patients have a real mild, just a little bit of hearing loss, but they really complain of horrible tinnitus, very severe tinnitus. Conversely, sometimes patients are profoundly deaf and you ask them about tinnitus and they're like, nah, I don't have any tinnitus, doesn't bother. I don't have any, don't notice it as well. So there's no correlation. So just because you have tinnitus or hearing loss does not mean you will necessarily have tinnitus, but the worse your hearing loss, it's more likely that you will. So that as hearing loss progresses over time for most patients, it's more likely that you're going to tell me you have tinnitus. So when to be concerned? Okay, like I said before, there are times that we do want to be concerned about tinnitus. And when we want to be concerned is when it is a sudden onset, like literally you wake up one morning and you're like, whoa, it's so loud ringing, or whatever the sound is. And that it's only in one ear, so we call that asymmetric. So it's a sudden onset, it's in one ear. You also are suddenly like, I can't hear out of that ear. You have a big change in the hearing in that ear, or you notice the hearing is going up and down dramatically. If you have vertigo, woo, this is not unsteadiness, this is not lightheadedness, this is not imbalance, this is a vertigo, spinning, right, tossing, nauseous and everything. Those are big flags. Also pulsatile tinnitus, meaning that you can hear your heartbeat in your ear. Now, we all might overexert ourselves and hear our heartbeat in our head, but this is very distinct. It's your heartbeat like in your ear. It's there pretty constantly. Sometimes tinnitus, again, will fluctuate, it will modulate, but this is your heartbeat. You can literally take your heartbeat and be like, yep, that's it in there as well. Pulsatile tinnitus is extremely distinct. It's very rare, and it's also very distinct. That I usually say, I don't usually have to ask someone if they have pulsatile tinnitus. They tell me because it's such a distinct thing that they come and go, I can hear my heartbeat in my ear, again, and we're talking about one ear almost always. So those are the times when we want to be concerned. Sudden onset, sudden, dramatic, one ear, pulsatile. Those are all, any of those things make us be concerned. And, an audiologist certainly would say, we got to get you over to a medical provider for imaging to start to kind of take a look in your head and see what's going on that might be the cause of that. All right, so again, like I said, tinnitus and hearing loss go hand in hand, okay? And so tinnitus is ultimately classified by how bothersome it is to a patient's quality of life. Again, this is completely subjective. It varies from person to person. Like I said, some patients have very mild hearing loss and they really can report severe tinnitus. Some people have really big hearing losses and they don't even think they have tinnitus. They don't even notice tinnitus whatsoever, as well. So this really comes down to a bit more, how bothersome it is a little bit more oriented to a person's personality and how they respond to stressors as well. So some patients just cannot tune out the tinnitus. And so it creates this emotional stress response by involving their limbic system, actually. So, I just say, gosh, some people just cannot not hear the tinnitus. It's just there all the time. And they end up kind of fixating on the fact that the tinnitus is there. And that creates stress for them because they start to go, gosh, I can hear this. And sometimes patients will come in and say, I think my hearing's okay, but I can't hear because of over my tinnitus. And now we're like, well, it doesn't really work that way. Hearing loss and tinnitus are separate, and the tinnitus is not actually interfering with your hearing, but it might emotionally be interfering with your ability to focus, especially in noisy environments, to say, gosh, I want to focus and tune out the surrounding noise and focus on what someone's saying. If you have very bothersome tinnitus, it's very distracting for you. And like I said, you sort of can't not hear it as well. Patients also can get, very, again, worked up about the tinnitus as well, and get very, like I said, emotional stress response in there too. And so it's the reaction to the tinnitus that actually causes this stress, not the tinnitus itself. So it's not like having tinnitus stimulates, some part of your system that causes this reaction. It is, again, that's where it's more of kind of a personality, the way individuals manage stress, is that it's the, that hearing the tinnitus, not being able to not hear it, becoming stressed and worked up, anxious over hearing the tinnitus. That's an emotional, or the way our mental health reacts to it, not the actual tinnitus itself that creates that kind of response. So for these patients for whom it is very bothersome and creates this emotional stress response, tinnitus is really, you could really kind of make it akin to a chronic condition, and really like a chronic pain condition. I often think about it, compare it often to patients who suffer from chronic migraine as well. It's a chronic stressor, chronic pain, chronic migraines, conditions such as that are stressors. And it can become very challenging for patients to continue to deal with that and to deal with it successfully. And like I said, some patients just can't not hear the tinnitus. They become then very worked up and anxious over feeling worried that something bad is going on inside their head is what they worry about. And it can become so bad. And for some patients, just this, feeling that this sound will never go away and they won't ever be able to cope with it, that some patients consider suicide actually. And actually about 9% of women with severe tinnitus attempt suicide, and 5.5% of men with severe tinnitus attempt suicide. So it's very rare that someone goes to that extreme, but it is very real that can happen as well. So for patients who are really having very bothersome tinnitus, we really encourage working with a mental health specialist. So cognitive behavioral therapist, someone who can help develop consistent stress management techniques, things to help disassociate from the tinnitus a bit, to know it's not there's not something bad necessarily going on inside your head, and that you have some tools to start to feel like you have a sense of control over it, and tools to help manage yourself and to disconnect from it, kind of disconnect your emotional response from the tinnitus itself. You can't make the tinnitus go away, but you can work on your emotional response to the tinnitus as well. So really, the help of a mental health professional is the best for those patients who are on that extreme end of their response to the tinnitus. For most patients, the tinnitus is there. It can be annoying, but it's not that extreme bothersome as it was that we were just speaking about. And again, because tinnitus is almost always related to hearing loss, we really try to focus on that, helping to manage the hearing loss. But there are other things that can, factor into how bad the tinnitus is being perceived by the patient. So, caffeine, alcohol, chocolate, those things are going to can make the tinnitus worse. Poor nutrition, poor stress management, poor sleep, excess weight, smoking. Gosh, all those things can actually contribute to tinnitus being perceived as worse by a patient, or it also be maybe more bothersome because of a difficulty managing the stress, that emotional response to the tinnitus. So I always kind of just say, hey, listen, facts of life apply to tinnitus. I think any kind of chronic condition, it's probably even more important that you maintain a healthy lifestyle, right? That we have good sleep. You're well hydrated, right? So not too much caffeine, not too much alcohol. Chocolate is caffeine, in many ways, but good diet, good exercise management, good stress management, good sleep hygiene, good hydration, that just makes life in general a lot easier to deal with. But I think when you have a chronic condition, such as tinnitus, even more so, you got to have those tools in place to be able to have a healthy lifestyle and to be able to manage that tinnitus the best you can. I've had many patients, when we have this discussion, will go, gosh, you know what? I have noticed that my tinnitus is worse. I would say, gosh, I remember a time a few weeks ago, my tinnitus was really bad, but you know what? Gosh, I was up real late that night before I was studying for a test. And so I had drank a bunch of coffee. So you're looking at, and I was eating a bunch of junk food, right? So poor nutrition, poor sleep, caffeine, right? All those things, and stress, and added stress, and notice their tinnitus worse. I have normal hearing. I do not have tinnitus. But I can remember being in graduate school, very stressful time in my life. And I can remember having tinnitus then. And so, it's just, it can be exacerbated by, the things that already make life more challenging as well. Caffeine, alcohol, poor nutrition, poor sleep, those things make it more challenging. So follow the rules of life for a good, healthy lifestyle. That'll help you manage the tinnitus better and help you be in a place to be able to adjust and use your stress management techniques to handle it if it becomes bothersome for you. All right. But what can you do? If you've got tinnitus, what do you do? Well, the first thing you really need to do is see an audiologist too. And they'll do a comprehensive evaluation. Okay. So very often when I see a patient who I know that their primary complaint is tinnitus, I already know I'm going to do a hearing test, but I usually kind of right out the gate, we talk about tinnitus. And I basically have a short version of this talk with them. I talk with them about the fact that, hey, gosh, for the vast majority of patients, the tinnitus is because of hearing loss is what that's for. And that your auditory nerve and your brain get into this feedback loop where your nerve is overfiring, trying to make up for the sound that it's missing. The brain gives it a sound, and then they kind of start this sort of cycle as well. I ask them questions about it. Gosh, is it in one ear? Is it both ears, right? Has it just been a gradual thing? Was it sudden? And if they're telling me, if they're not giving me any red flags, it's in both ears, it's been a gradual thing, it used to come and go, but now it's there all the time. I always say, listen, it's certainly not likely there's anything bad going on, in your head. And this is really most likely just because you have some hearing loss. And then we can get in and we can do our testing, we can evaluate their hearing, and then we can talk about treatment options for them. So for treatment options, so very often for many patients, patient education, just that discussion that sometimes that's enough for them to just have an understanding of where the tinnitus comes from. Again, that it's not this, if they don't have any red flags, it's not a flag for anything bad going on in their head, then they go, okay, I don't have to worry about that. But then for patients who, when we do our testing and we figure out that they have, almost always, they have some hearing loss, and we obviously know they have some tinnitus, we start talking about what we can treat. So, first and foremost, we try to treat the hearing loss. If the cause of tinnitus is because of hearing loss, right? Nerve is overfiring, trying to make up for sound that's missing. By treating the hearing loss through, let's say, most commonly hearing aids, you put on hearing aids, you bring back a lot of the sound that the ear is missing. The nerve gets what it was looking for, and it calms down, and it doesn't overfire as much as it used to. And so very often the hearing loss or the tinnitus gets better when a patient's using hearing aids. For some patients, we do a combination. There's a thing called sound therapy, which is usually the recommended management strategy. And that helps us, we do this by introducing sound into the environment, and it basically distracts your brain from focusing on the tinnitus. So it distracts it with a less annoying sound so that you don't focus on that tinnitus, that ringing as well. So we might first and foremost try and treat the hearing loss, because 70% of patients who have tinnitus find relief just by treating the hearing loss. That means we have about 30% that don't find relief, that even though we treated the hearing loss, the tinnitus still persists. For those patients, then we start to go into the sound therapy, where we're trying to play some sounds that help to distract the brain from focusing on it. So we're kind of doing two things very often as well. We call these masking devices, or what we call these two. Maskers can be kind of a variety of things that we'll talk about in just another couple slides. Very often, if we're going to do a tinnitus evaluation, so for many patients, we come in, we actually do a hearing test. But for some patients, again, who find the tinnitus to be quite bothersome, we actually may then perform a few extra minutes of testing called a tinnitus evaluation. And so with the tinnitus evaluation, we're going to do a regular hearing test to evaluate your hearing. And then we're actually going to do things that are called pitch matching, loudness matching, and masking levels, finding a minimum masking level. So pitch matching means that what I'm going to try and do is I'm going to try and see if on my test, with my test equipment, I can narrow down and match the pitch of the tinnitus that you're hearing. If it's a low sound, if it's a high sound, I'm going to see how close I can get to it. See if it's within a range that I can match. And then I'm going to see if I can match the volume, right? So I'm going to play a sound in there, and then I'm going to keep adjusting the volume until you say, yeah, that's about as loud as my tinnitus is. Because again, that's completely subjective. It's completely just what you perceive yourself. And then I'm going to actually try and put in some what's called masking. So again, a kind of a noise to try and cover up the tinnitus. And I'm going to see, can I cover up the tinnitus? Can I turn up the volume enough that it covers up the tinnitus for you? And all that information is real helpful for me being able to predict the likelihood that sound therapy may help someone as well. Additionally, we're going to usually do a self-assessment, so a questionnaire that is specific to tinnitus and how it impacts the quality of life for any patient. So sound therapy, like I said, sound therapy is when we introduce other sound into the environment or into your ears to distract you from your tinnitus, okay? So it distracts your brain with another less bothersome sound, all right? The advantage to this is that the sound can be controlled by you, right? Your tinnitus, you can't control your tinnitus. It's just there. It just is, and you can't control it. And so this is real helpful because you can start to feel like you have some control. You can influence the tinnitus in some way. And so the way we implement sound therapy is really two primary ways. The first is they're called environmental maskers. So we use it in the environment. And that's just things like putting on a fan, right? That little bit of a hum of a fan is sometimes just enough to cover up tinnitus for patients. Maybe a little bit of music, or nowadays someone might listen to like a podcast or a book, just nice and low, just enough to kind of, again, keep you distracted and your brain doesn't latch on and notice that the tinnitus is there. A classic thing is a noise machine, a white noise machine as well. Again, anything that introduces sound into your environment to help cover up. You can then also do it you can do that environmentally, or you can do it ear level, basically the same things. Nowadays with AirPods and earbuds as well, many of us can do that, listen to a little bit of noise, a little bit of music, a book, a podcast, just at a real low volume, enough to kind of cover it up for you. The other way we introduce sound therapy is through hearing aids, actually. So they're actual hearing aids, but they may only play these sounds in your ears. Most commonly, it's called a combination device, where we're actually it's a hearing aid to help treat your hearing loss. And then should you fall in that 30% where treating the hearing loss doesn't really take care of the tinnitus enough for you, we will then implement these sounds. We'll then activate these features where we can play these different sounds in there. So we can help your hearing loss, and then we can play these little sounds to help try and distract you from the tinnitus as well. This is a super common complaint. My tinnitus is worse at night. And we usually say, yeah, you know what? It's actually probably not worse at night. It's just that it's quiet at night. And so you have no distractions to distract you from hearing it as well. So we often like to give this the analogy of a candle that's in a dark room versus a candle that's in a well-lit bright room as well. So you want to think of the candle as your tinnitus, right? That's your like ringing in your ears. And then the darkness is your quiet room, okay? So if you light a candle in a dark room, so your tinnitus in a quiet room, oh my gosh, you can really see that light glowing from across the room, even a little tea light you can see glowing, okay? But if you take that candle and you put it into a bright room, all of a sudden it's not nearly as noticeable, right? You're like, yeah, it's there, but it's just not as dramatic is the thing. So the light room is what we would compare sound therapy. So if we go back, you go in here, this is just you and your tinnitus, doing your normal thing. You're like, oh my gosh, there's that light. Oh my gosh, there's my tinnitus, right? Then let's say you do sound therapy. You put on a fan or a little bit of low music into your environment in your room. Now, yeah, tinnitus is not, you might notice it some, but it's not nearly as dramatic as when it was quiet in there, okay? It's just the stark difference, the stark contrast. We want to, for patients who find tinnitus very bothersome, there is this stark contrast between their tinnitus and the rest of the world. What we want to do is we want to blur those lines so that contrast is not as dramatic. There are, outside of sound therapy, again, treating the hearing loss and sound therapy are the most common treatments that work for the vast majority of patients. For those patients that those types of treatments don't work, there are other treatments out there. There's something called tinnitus retraining therapy, progressive tinnitus management, there are tinnitus activities treatment, and there are various support groups. The VA is actually really quite good at offering these groups because tinnitus is a very, very common complaint with veterans as well. So these are, on the next slide here, are a kind of a variety of resources that you can access to research those things. To be honest, I'm not aware of anywhere in Tucson that specifically offers like tinnitus retraining therapy as well. But audiology private practices in town are usually very good at offering some really great tinnitus resources. Again, most audiologists are going to offer combination devices, so hearing aids to treat it, where they can activate tinnitus masking features in there. But there are, again, if you find that your tinnitus is quite bothersome, you just may also investigate some of the local private practice audiology clinics because they're usually real great at adding that kind of real specialized high-level care in there as well. But here are some other resources that you can certainly reference to educate yourself on. One of the best ones is the American Tinnitus Association too. Very great resource for lots of good information, okay? Again, this is just a reminder, right? Healthy lifestyle makes it easier to deal with the potential stress response from tinnitus, okay? And then that's it for my slides, actually. So thanks for your time and consideration in there. And then I'm happy to answer questions.
Well, that's great. Thank you so much, Dr. Bourn. I've got actually several questions that came in during your presentation. So one was actually about tinnitus coming and going. And could it be stress that's affecting that as it comes and goes? And you did sort of talk about that, but if you would just sort of comment whether you feel that that might be, they get it and then it's gone for a while, then it's back. And you're wondering about stress being related to that.
I mean, I think it certainly can. I always say, I can't say for sure that it does or does not, because tinnitus is completely within our own mind, in our head, not our mind, but it's within our own body that, it's difficult for us, as a evidence-based provider. I'm always looking at how can I calibrate and actually measure things as well. And so tinnitus is a challenge because it's subjective. So I think, for patients who maybe notice that, one of the best things you can do is journal and, document to see, gosh, is there a correlation that you're seeing with it? I think certainly stress can add to it. Like I said, healthy lifestyle certainly makes managing tinnitus better, but it also can make it worse. I think I think certainly it can be, but also paying attention to, is there changes, other fluctuations in hearing? Again, is it one ear? Is it both ears? Those are sort of things. So probably for that specific question, journaling to document is probably one of the most helpful things.
Okay. And then if somebody needed an appointment for, to be sort of evaluated, you would be available to do that as well.
Yeah.
I have the number here that I'm going to put up on the screen. And that is to make an audiology appointment over at TMC.
Mm-hmm.
You do require a referral from your physician in order for that. And that is the phone number for central scheduling. And my understanding is they can request, if you're available, to have you for your appointment. So I did want to put that up. The number is 520-324-2075. Mm-hmm. I have some other questions that came in, and one was about the pulsatile tinnitus. Basically, it sounds, and just tell me if this is appropriate, that you would that's something that should require some further evaluation, correct?
Mm-hmm. Yep, absolutely. Okay. So pulsatile tinnitus, I'll tell you. So pulsatile tinnitus, like I said, it's a red flag, hearing your heartbeat in your ear, and it's consistent. Again, we all kind of overexert and go like, oh, I hear my heartbeat in my head. But, when it's not prompted by, an overexertion, we definitely want to get that evaluated. Very often there are other symptoms that can go with it, not always, but if you have pulsatile tinnitus, and what you also notice is you get brief duration vertigo where you're like, whoa, I feel real spinny. Maybe when you like lift something heavy or like exert yourself, or a loud sound makes you dizzy again, or this increased awareness of your internal body sounds, things like the way someone's described it to me as, she said, gosh, like when I eat food, it's like I have a mouthful of rocks. It's like I'm chewing rocks in my head, So there's some other kind of distinct other flags that go with that as well. But hearing your heartbeat in your ear, again, consistently is definitely a flag that needs to be evaluated.
Okay. I did have a question that came in about hearing aids, and do hearing aids boost sound to overcome the hearing loss? For instance, this person says that they have a drop off at one end. Oh,
well, so hearing aids, the goal of hearing aids, right, is to bring back, I always say hearing aids aren't just volume, but they're a lot volume. That's what they really are. They're a more sophisticated shaping of the frequencies, because when we have hearing loss, we have usually have hearing loss like this person saying, oh, I have hearing loss at kind of one end. So some frequencies have hearing loss and some don't have hearing loss. So hearing aids, really the main goal of hearing aids is to bring back a lot of audibility. So you develop hearing loss, hearing aids are going to help bring back a lot of the sound that you're missing to make it a bit easier. So I don't know if that exactly answers that question, but hearing aids they try to do a boost, but it's not like a flat, it doesn't just boost all the sounds. The idea is you're going to try and give a little boost to the sounds where you need more help, and not interfere with the parts of your hearing that are normal in there. I always say nobody can compete with Mother Nature. My students probably get tired of hearing me say this. I always go, nobody can compete with Mother Nature. She's the best engineer that has ever existed. So in regards to hearing, hearing devices are always what we hope for is they're going to be better with the device than without, but it's still never perfect.
That's a great answer. Okay. I also had a question just asking about new treatments for tinnitus. I guess there was a story on this morning just on NPR about new treatments, and just wondered if you knew of any treatments, anything new that's coming out. Apparently there's some new things that are happening in Europe with some vibration, and also with stress and some sort of anxiety and stress. And I didn't know if you had heard of any of those. I have not heard about that. And so, certainly again, in our field, we're going to focus a lot on what comes out, what the peer-reviewed literature is that comes out in our field. So certainly what goes out into the general public, is one thing, but we're typically going to be a little slower reacting until we have some things that have been peer-reviewed as well. But certainly it's a big deal for a lot of people, right? There's lots of different treatment options lots of homeopathic treatment options that people try.
as well. But I think certainly it makes a lot of sense to me, the stress management, because again, that really is the emotional response that someone has to their tinnitus. And again, it's not the tinnitus that causes that. It's just your own personality. It's a personality kind of thing as well. And so that ability to be able to manage that stress better and that response to it helps to give the patient a lot more control, over it, and just can help to alleviate that reaction, that strong reaction to it.
Great. And then I just had another one just asking about, you said that one type of are there more than one type of masking noise? Like, she's found that masking noise can be more annoying than the tinnitus itself.
Yeah, for sure. No, there's so many. It used to be that it was just kind of white noise is what they would call it pink noise or brown noise, but it was just some type of a noise. Now there's all sorts of things. There's a lot of ways you can experiment on your own. You can literally just especially on smartphones, you can find tinnitus apps that most of them are free, and it will just have a plethora of sounds. Sometimes it's like spa sounds, right? Like a babbling brook or like flutes playing, it can have that. It can have the noise. It can have, when we do hearing aids, a lot of times it's this frequency shaped noise because we're trying to shape it around where the patient's tinnitus is the worst. It can also be what are called fractal tones, which are these weird like ching, 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 ching sounds. It's just unusual sorts of sounds. It doesn't really matter what it is, as long as we find something that works for a patient. But that's not an uncommon thing to go, ooh, that sound is horrible. That sounds worse than my tinnitus. I'll take my tinnitus over that sound as well. So there's a huge number, but lots of patients can actually just experiment and investigate it themselves through their smartphones, and find apps that have it. And great, just put on some earbuds and experiment and see what you find.
That's great advice. I know if you have something that's annoying you, that doesn't help, but no. It sounds very custom in this case that you can definitely hopefully find something that would alleviate the issue a little bit more.
Yes.
So, I want to thank you so much for being here, Dr. Bourn. This was great. We do have a presentation. We've got a couple of presentations this week. One is our cooking club that's tomorrow at 1:00. But on top of that, we do have hearing issues as we age, and that will be with Shauna Bone from TMC as well. So you can see her on Thursday, June 17th at 10 a.m. So I want to thank everybody for being here, and we hope to see you at our next presentation.
Thank you.